So my name's Jacqueline Shreibati, and I'm here today speaking on behalf of my hat as a practicing physician whose day job is at Google, and previously I was the chief medical officer at AliveCor, which is an EKG startup. Yeah, I can speak louder. And so a lot of folks want to be involved in the digital health revolution or working with digital health companies, and it can feel very disengaged from the process. So I wanted to kind of give a pragmatic how-to guide to bring digital health into your practice. Okay. So I'll be outlining the digital health landscapes, in particular how it pertains to cardiovascular disease management. I'll be providing some ideas on how to incorporate a reimbursement model into your practice. And you'll see that many of the lecturers already have discussed how complicated the whole process of implementing digital health into healthcare can be. But I will be also bringing up not only the challenges, but the benefits of implementation. So the 2020 landscape for digital health is pretty overwhelming. There's all different ways that companies are getting involved. And since 2011, more than $30 billion has been invested into digital health. And what I found kind of ironic is that patients who are employees at self-insured companies are often exposed to the latest and the greatest. So if you're at a large company, at a self-insured company, you might get coaching from Omada or Livongo. You might get exposed to health benefits from Grand Rounds or Collective Health. But the reality is that the physicians may not be exposed to all these different modalities. Perhaps as consumers, yes, but as physicians in practice, no. But one of the ways that physicians might be exposed to digital health is through remote patient monitoring. And this often comes as an introduction through our patients who are coming into our office with some latest gadget or some latest app on their phone. Remote patient monitoring is simply the collection of data from patients outside of traditional clinic environments, and it's typically used for monitoring or treating patients. It's been around for quite some time. They say that the beginning of remote patient monitoring, or RPM, began in the 1960s when NASA was monitoring astronauts from outer space. And then from the 1970s to the 2000s, this was very commonly used in large health systems like the Veterans Administration and Kaiser, but they were transmitting data from home using a fax machine or a telephone line. So now we jump into the 2020s now. Hi. And we've given up the fax machine to some extent, at least in the home setting. We still have them in practice. And now we have high-speed internet. And does this matter? Do patients want RPM? They may not know that's what exactly RPM stands for, but there's an increasing number of patients who are asking for physicians to track them in between clinic visits. You can see that for the folks I usually see in clinic who are over the age of 55, it's only a fraction, but it's a growing proportion of folks, particularly younger ones, who want the convenience and the accessibility of being monitored in between a visit. And maybe they never come into the clinic at all. It's all done remotely. Even if your patients today don't want it, a lot of people strongly believe that remote patient monitoring is inevitable. Because in just 10 years, over 20% of the population will be age 65 years of age or older, and up to a third of physicians will be as well. And that means that there'll be less funding for Medicare, and there'll be less physicians to take care of a Medicare aged group. And so the idea is that RPM might be a way to address some of these demographic changes and funding shortages by keeping people the so-called aging in place theory, where they're staying at home and receiving their care at home. Unfortunately, since we've been doing RPM since the 1970s, there is a swath of evidence that supports its efficacy. There's been over 17 systematic reviews. 200 papers were included in this analysis by the Agency for Healthcare Research and Quality, and included 50,000 patients. And this group felt back in 2016, that there are certain groups of patients that very much benefit from remote patient monitoring. It often includes folks who have COPD, or asthma, or heart failure, or diabetes. Of course, the holy grail for not only digital health, but any other technology in healthcare is that it's satisfying these quadruple aims. And we do hope that RPM will not only improve population health and the patient experience, a lot of digital health companies have already demonstrated this, but it will also result in a reduction of costs and the improved provider experience. You can imagine a time where the people who are healthy stay home, and the folks that you see in clinic are really the ones that not only have a more acute pressing concern, but are really best served in the office setting. And of course, this is something that will take many years to change in terms of physicians' expectation, and I think it will have to take place in medical school training as a kind of a redefinition of the types of people that we see in office versus at home. Another thing I would bring up is that there are digital health companies that are working on addressing and evaluating social determinants of health, because there's growing evidence to show that we can't achieve any of these aims without consideration of those factors as well. But let's come off the soapbox and just be practical and realistic here. Our physicians, are we ready to adopt RPM in 2020? The AMA put out a survey of over 1,300 physicians a handful of years ago and asked them if they were interested in RPM. And this is a typical technology adoption curve where less than 15% were actually using it and less than 50% were enthusiastic about it. And I heard some discussion about this earlier this morning, and it's echoing a similar concern because physicians' excitement over RPM, or for that matter, any new technology, is dampened by the concern of any disruption in their day-to-day workflow. So you ask, oh, I want a technology that improves work efficiency, but doesn't actually change my current day-to-day workplay, and it doesn't require any special training. And it's really hard to do both of those at the same time. It's going to be disruptive in positive ways and probably negative ways in the short term as workflows and definitions of how doctors interact with patients continues to evolve. In the cardiovascular digital health space, where I practice, I think this is the most kind of tangible example of sensors and RPM being used in clinic. Even if you are not using RPM in practice today, I bet you have many patients who have shown you either in clinic or on rounds their latest wearable or health tracker. It's inevitable, and I do think that patients and consumers are going to be the ones that are propelling widespread use of RPM as a healthcare delivery mechanism. So you can see here we have both apps that are tracking heart rate and steps. Some of them are also cleared to detect arrhythmia as well. You have EKG, whether as a portable device or as a wearable, or even on blood pressure cuffs, they have EKG these days. And then there are new and innovative ways of identifying heart sounds, even in the home setting by patients. Most, but not all, are regulated medical devices, and this could be a topic in and of itself, selecting the right sensor for your practice. But they're out there. A lot of them are direct to consumer or very easy to acquire. And in practice, you're going to have to think about, do I incorporate this? Is it worth my time? What patients are best suited for using this data in between clinic visits? On the right, I would remind you that despite all of the flashy new digital health, all of the major companies who have market share in blood pressure cuffs, scales, pulse oximeter, diabetes management, they've all developed form factors that are now smartphone enabled, much more convenient to use, that can connect to various portals. And so they are also part of this ecosystem as well. So integration is not as easy as 1, 2, 3. But when you want to think about how am I going to bring some of this into practice, let's say in the next 6 to 12 months, some ways of thinking about that is doing your own literature search, working with your group to figure out which sensors are my patients using already. Do they already have them at home? Can I incorporate those so they don't have to pay for any additional new technology? Look to see if it's been clinically validated. Ask your patients if it's user-friendly to them, because they're the ones who will be using it at home. Number 2 is not easy, by any means, is probably the most complicated one is trying to figure out how you're going to receive that data and document it in your EHR. But there are not only companies, but vendors that do this as well, and many EHR also offer platforms to facilitate RPM. Because it's less complicated, I'm going to focus on number 3 in the next couple minutes. So there are several reimbursement and business models that are out there these days, and probably the most important thing is once you have a sensor in mind, you have some sense of getting that data and documenting it. You'll have to probably propose some type of business model to your group, and there are several ways of doing this these days. The other option is that you can kind of do this on your own, ad hoc, where you can kind of submit the claims and see where you can go. It's not going to scale, but a lot of companies or a lot of physicians who want to get involved are doing this kind of at a practice by practice level and working with the payers. I'm not a billing consultant. This is just educational, but this is kind of what I've seen in my experience, both at San Mateo Medical Center as a practicing physician, at a LifeCore, and now where I'm at today. So there is fee-for-service models where you can incorporate RPM. It's a little bit less direct, but for the over 900,000 clinicians who are participating in merit-based incentive payment programs, 15% of your score comes from the improvement activities, and you can use RPM as part of that score. And that's an increasing popular way to get on board using RPM without having to go through a committee to get compliance on board with CPT codes, for example. In 2020, there are several new groups of codes to facilitate RPM and digital health adoption, more broadly speaking. And to be clear, there are codes here. They don't equal coverage. You have to go through your clinic to get them on board with compliance, and then every individual payer will have their notion of if the codes can be used or not, but this is the basic framework that we can use nationally to think about adoption. So new in 2020, there are these online digital EM services codes, and basically if a patient initiates a concern through a HIPAA-compliant app or portal, if a physician reviews that information and works with their staff to develop a plan, a treatment plan, say, write prescriptions for a COPD exacerbation, all of that time can be reimbursed. And it depends on the amount of time that you're spending on that particular concern. But over 21 minutes can be reimbursed on average of $50. Now, the big asterisk with this code is that if a person, for example, uses the EHR to make a complaint about a breathing complaint, and then they come in later that week to see you in clinic, the time that you spent addressing it from a digital point of view has to be attributed to your in-person visit. Oh, thank you. So then you don't get separate reimbursement. So there are these interdependencies with the in-person visit with the digital evaluation, but it's a good first attempt, I think, by the AMA and then CMS broadly accepting these codes to acknowledge all the time that clinicians are spending on the EHR addressing telephone encounters and really taking care of their patients while they're at home but not getting paid for it. And there are also codes that will also reimburse your staff and also the qualified non-physician healthcare professionals, albeit at a lower rate. But again, acknowledging that there's a lot of work keeping patients at home, addressing their concerns by email or other apps, and this is a way to track your time. There are a bunch of codes. This slide is not meant to be easy to read, but just to give you a sense of, there's a lot of codes basically for education and setup, for the device supply, and for interpretation of data that's coming from these technologies. They've been around since 2018 to 2019. Probably the most important thing to note as a physician that would be like the 99457 code. You can have your clinical staff be working on these projects. It's not just some physician time, because this RPM is often provided directly by clinical staff and not necessarily by the physician. And it's also a code that can be done under general and not direct supervision. So this is really starting to facilitate the use of third parties and other groups to manage large swaths of data and really scale an RPM practice. And finally, there's a couple new codes that are coming out for self-measured blood pressure, which has been shown to predict cardiovascular mortality better than in-office blood pressure measurements. It's not very much, but it's an acknowledgement that if patients are already monitoring their blood pressure, usually when you've initiated blood pressure medications or there's a change in the blood pressure management, that there's usually intense evaluation in those first couple weeks, that physicians and other qualified healthcare providers can get reimbursed for their time. And it's important to note that you don't need to be doing this electronically. This can just be a review of a journal, which is usually how I get the blood pressure data these days in clinic. If you're interested in implementing digital health into your clinic, albeit even if it's just a pilot, I highly recommend reviewing this AMA website. They have a playbook. It goes into everything from needs assessment to getting everyone in compliance on board, to doing a pilot, to evaluating the steps and seeing if it's worthy to be scaled in your group. It's fantastic. RPM early adopters, they kind of range the gamut. The ones that are probably the most well-publicized are the large integrated delivery networks, larger academic institutions, but a lot of solo and small practices have the flexibility of adoption as well, and they don't get highlighted in the paper, but there are lots of practices who are using this to take care of primary care patients in the home setting. And there's also a slew of vendors. I would just say that if you are evaluating the vendors, sometimes the user interfaces can be mind-boggling. There's an attempt to give a sense of modularity and adapt to everyone's needs and preferences, but really make sure that you're bringing in your clinical staff, the people who are actually going to be looking at these user interfaces, and make sure that they can use it, because it can be overwhelming. And I will brush over this, but this is probably some of the most complicated and also intellectually interesting and current topical issues today. But if you're going to scale the technology, you're going beyond the pilot. When you're really starting to think about risk and accepting risk in your practice, you have to start thinking about data privacy, reviewing the terms and conditions of that vendor that you're working with, understanding where the data is residing. Is it cloud-based? Is it on servers in your clinic? There's lots of questions to go over, and I think all of us are becoming a little bit more educated about the details and the complexities of these relationships. So this kind of goes along with scaling any type of vendor in your practice for RPM. So I hope that I've given you a little bit of a taste of the promise and some of the challenges of adopting digital health in your practice, and I'm happy to take any questions during the Q&A.
Thank you, Jacqueline.